is Carlos de Castro. I'm a professor of medicine in the Division of Hematological Malignancies and Cellular Therapy at Duke University in Durham, North Carolina. So PNH is a fascinating disease. It's incredibly rare. And up until 2005 or so, we didn't have any great treatments. Until then, the complement inhibitors, of which eculizumab was the first one, were developed. And eculizumab targeted C5. C5 was picked as a target of complement, in part because it was felt to be one of the safest points to inhibit complement, and that we wouldn't get into too much problem with infections. Later, ravulizumab came out. It is a much longer acting form of eculizumab, and really we were that way for a long time until the past few years, when we now have a total of 6 complement inhibitors that have been approved for treating PNH. Some of them are what we call proximal inhibitors. That is, they act earlier in the complement pathway. And we have pretty much shown that they're very safe. They do not cause an increase in infections, which was our initial concern. With 6 complement inhibitors out there, the big question is now, which one should we choose to treat our patients with, and how do we make that decision? And there is no right or wrong answer here. They're all highly effective at treating PNH, so don't get me wrong. What we did in this abstract is we took a retrospective review using claims data, with all the concerns that we have about using claims data, to see how patients did in the real world when treated with either a C5 inhibitor, when they were switched from a C5 inhibitor to a proximal inhibitor, or when they were just started on a proximal inhibitor alone. And we wanted to compare the groups in terms of the hemoglobin they achieved and the need for transfusions. And that's what this whole abstract was about. And hopefully we can submit it for publication one day soon. The results data pretty much speak for themselves. Obviously, the majority of patients received a proximal inhibitor because we went all the way back to 2015, and we didn't have any proximal inhibitors then, so they were all on C5 inhibitors. And most of them had hemoglobin levels that were in the range of 10 to 11, which is okay. The ones who switched, however, clearly had an improvement in their hemoglobin level from their baseline. And then the ones that were on proximal inhibitors in general tended to rise a little bit more and had better outcomes at the final follow-up standpoint. So on average, patients on a terminal inhibitor or C5 inhibitor had a hemoglobin of 9.3 when they started, and it ended up around 10.8. Patients who were on the switch group had a baseline at 8.1. When they finished their C5 inhibitor, they were about 9.5 hemoglobin grams per deciliter. And when they switched over, they achieved a hemoglobin on average of around 11 grams per deciliter. Patients who just went on a proximal cohort, proximal inhibitor right at the start, rose from a baseline of 10.4 up to 11.4 at follow-up. So again, the results tend to show that the proximal inhibitors seem to have a better chance of achieving a close to normal hemoglobin level. You can also look at that graph that we divvied them up into what sort of hemoglobin did they achieve, and a sizable percentage that were on proximal inhibitors got to a hemoglobin above 12 grams per deciliter, what we would consider normal. The other thing we looked at then was transfusion burdens and transfusion dependence, and certainly they all seem to improve transfusion dependence. The ones that had the biggest decrease, though, were those that got switched from a proximal inhibitor from a C5 inhibitor to a proximal inhibitor. There are limitations whenever you do a study like this, a claims analysis, including missing data and events occurring outside of the insurance coverage that may not have been shown here. In general, though, what this tends to show is that PNH patients who are treated with a C5 inhibitor may still have anemia and transfusion needs, and that if we look at hemoglobin levels, the proximal inhibitors seem to give a higher hemoglobin level, whether they're switched from a C5 inhibitor or whether they just start out de novo, and they have a better chance of getting transfusion independence on a proximal inhibitor. Now, there have been no head-to-head studies of any of these agents in a truly naive population. That would be an incredible, difficult study to do and also very costly. So for now, this is the data we have to suggest that maybe proximal inhibitors should be used more often than the C5 inhibitors. Having said that, there are plenty of patients on C5 inhibitors that do very well. So it makes it very difficult still for us to decide which inhibitor to use. So many physicians have argued, hey, we've had the C5 inhibitors for over 15 years now. We should probably be using them more often because we know they're safe and effective. I think this data just adds to the data suggesting maybe proximal inhibitors are just as safe and maybe a little bit more effective.